Okay, thank you. And so here I'm talking about regional risk, and this kind of fits in with the very first presentation, ventilation, which fits in with what Kevin was just talking about, and we've been talking about masking all the way through. Here's the diagram I was mentioning before. It's the death rates per million people for Canada in blue and Denmark in orange. And you can see how high Denmark's are. And noticed also in the chat that the Denmark's is much more underestimated than Canada's is. And here's where Denmark decided to drop all its protective measures and use right when the steep climb was happening. And the reason they gave is they decided that their population is responsible enough that they can manage the pandemic at an individual level, not requiring state intervention. And well, we see the results. This is a trend, obviously, going in Ontario, and also Public Health Agency of Canada just before Christmas put this out. And basically, they're downloading the responsibility for assessing the risks and determining what kind of precautions to take to the individual. And in sociology, there's a term for that. It's called responsibilization. And in one section here, one of your responsibilities is to assess the COVID-19 activity in your area. So how do you do this? Well, our first presentation showed an attempt to try to do that. We've also tried to, this goes back to July and August of 2020 when we put this together, so it's a little bit dated, but it was based on escalating advice based on your regional risk and broken down into the 7 areas of communicating, cleaning, hand washing, ventilating, distancing, screening, and masking. And here are the criteria that we use for defining risk: minimal controlled risk, some community risk, wider community risk, and high. And it's based on the number of cases per 10,000 people in the last 14 days. And I've converted that to 100,000 because the province decided later on to create something that's based on 100,000 people, but they don't use 14 days, they use a week. And so, you know, there's a bit of back and forth in trying to, but I've placed these so they roughly line up fairly good with each other. So the green is fairly close to the green and yellow, etc. However, Public Health Ontario decided not to use red anymore, and they changed that to purple. And this was the map that was there just a few days ago, and you'll see here only Peel is below the purple and everyone else is in the purple range. And again, as the other speakers mentioned, you wonder why we removed the mask mandate. And if you want to compare the numbers for those people who are statisticians, here is the comparison. We also have a graph that shows the timeline. I remember when we first made the graph, we were wondering what the scale should be, and we were thinking 20 should be enough, but now it's quite the ride. And we also have it in a table form, and this was yesterday. So in our format, there's only Peel. In the 7-day format, Eastern Ontario and Ottawa is also one level below the control. And for each of the 7 items, here's the one for face coverings and maskings. We put together advice, and you'll see it's color-coded to match the risk level of the. So if your risk level is low, wearing a mask is basically a symbolic, a token of solidarity. Remember, we said this in July 2020. The symbolism of a mask has changed since then. And when you're in the green, things are controlled, but you need to be ready. And once you're into the yellow and orange, wearing a mask or a covering is good manners. You're keeping your emissions to yourself. It's breathing etiquette. However, once you're into the high risk, uncontrolled community outbreaks, then you need both etiquette and protection. And that's when you need an N95 or better. And then you can expect to be exposed if you're out and about in those conditions. Now, we have that one trend of trying to download the responsibility to the individual, but in health and safety, we also have an opposite trend, which is the bureaucratization of safety. And while it does have some benefits, it also starts to stagnate any innovation and development. It also creates games that people play with numbers, etc. So there's quite a few negative effects when you over bureaucratize safety. This is an example. This goes back to, again, 2020. When you enter a healthcare facility, I usually come in wearing an N95 mask, and I'm asked to remove it. And with a set of tweezers, they give me this this type of mask. And we know from the type of filtering and fit testing data that's available that these masks are not equivalent. You're asking, and these are N95s, and I'm wearing an N99, which is fit tested. And so you can see what a drop in protection that is. In fact, wearing a surgical mask is about equivalent to putting the hand over your mouth and nose. Also, this bureaucracy can create burnout. People can get emotionally exhausted, depersonalization, inefficacy, confronting health professionals of all types. It really drags things down. It creates gridlock. And I don't know if you've ever heard of Campbell's Law, but basically it says that a quantitative social indicator, when it's used for decision making, it becomes subject to corruption pressures, which are more apt, and the more apt it will be to distort and corrupt the social process that you're trying to monitor. And Robert Sass, who used to be the Minister of Labor in Saskatchewan in the 70s and is the original architect of the 3 R's, the right to know, the right to participate, and the right to refuse, which our Health and Safety Act is based on. He was asked how the 3 R's are doing, and he was quite disillusioned, and he actually says he feels the 3 R's have been co-opted into the 3 C's: collusion, corruption, and criminality. And the right to know, he suggests, is been co-opted by company-sponsored research, which clogs the scientific journals and doesn't serve the information needs of workers. Also, professional or expert health and safety knowledge undermines worker experience by substituting the knowledge derived from these corporate and government researchers for the knowledge that is based on the experience and the concerns of shop floor workers. An example is a company called ChemRisk, and in this is their old website, but they actually bragged about the fact that they had more than 1,000 papers presented at scientific conferences and 400 papers published in journals, and these are used and referenced in regulatory decision making and relied upon in litigation proceedings. So companies that are being sued for malpractice or reckless exposures to the public or to workers are publishing these papers and using them to defend themselves in court. Also, the right to participate has been co-opted by the internal responsibility system, which came from the Ham report. And this is because workers' recommendations do not have to be acted upon. They only have to be consulted. And this comes from a book called Consulted to Death by Doug Smith. And without these other 2 rights, the right to refuse is severely weakened. And when I remember when the Occupational Health and Safety Act first came into effect in the late 70s in Ontario, and employers were screaming that it would shut down business and it would be impossible to work with. But as it says here, the tiger employers once feared and fought turned out to be a mere pussycat. And in fact, the prohibition against reprisals, which is necessary if you want to exercise some of these rights, has been shown in practice to have serious limitations. And there's some work by Andy King and others who basically concluded that there are serious gaps that discourage workers from exercising voice and limiting the effectiveness of the IRS in improving health and safety outcomes. So this got me to thinking that, especially when I heard stories about workers who were being disciplined for wearing superior masks than were being provided by the workplace, that there should be something in the Occupational Act that gives a worker a right to additional protection based on their own personal risk assessment, something like the healthcare point of care risk assessment. It's not just the risk in their workplace, but also the risk they pose to others in their social bubble. We heard of a teacher who had an immunocompromised child and therefore wanted to wear an N95 to school and was disciplined with 3 days off for not taking it off and wearing a surgical mask. Remember, that's the equivalent of putting your hand over your mouth. And those who don't need feel the need for such protection should be understanding of those who need to exercise this right for self-protection and other protection too. So what lessons have we learned so far? As has been mentioned by Kevin, SARS-CoV-2 is transmitted in close range, so we need to spread out. It's crowded places are a problem, so we need to take turns, control the flow of people through indoor spaces, have creative scheduling, find out other ways of doing things, like do we really have to be there or can we work from other places? And we know that it comes out of your nose and your mouth, so let's be a little polite and cover up your emissions and keep them to yourself. At close range, it's transmitted by airborne routes, so the better the mask, the better the fit, the longer we wear it, the better the protection. Dilution ventilation lessens the risk, so let's bring in more fresh air. And Kevin showed this already, but I want to re-emphasize this. All this is the hierarchy of controls that NIOSH put out, but turned on its side. The hierarchy says if you got the top, you don't need the others. However, I've turned it on the side because we need all of them, because each protection on its own is not sufficient. Vaccinations are good and necessary, but they're not perfect. Ventilation is good and necessary, but it won't do it all. We need them all at the same time, not in a hierarchy, but rather in layers. Now, here's the tool that Kevin was mentioning. We put together. It's a spreadsheet, and it has 5 sections in it. And the first section is all about just describing the size of the room, the number of people there, and the type of ventilation system you have. The second section is the difficult one. This is the one where you're trying to figure out how much air is flowing through it and through your room. And this is, there are different ways of doing this, and you can ask somebody who knows, but then again, do you trust that they know what they think they know? You can find out, you can look for criteria, building codes, things like that. You can check, you can have somebody you trust who has access to the ventilation drawings and look there, or you can have a look inside the HVAC with somebody who knows what they're looking at. You can assume, there are some rules of thumb. You can make some basic assumptions, X many square or CFM per square foot, or X many air changes per hour. You can actually get someone to measure it, somebody competent. That's the best way of doing it. But you can also learn how to do it yourself. And we have a video online which actually shows how you can fill a plastic bag which is placed over an air outlet and time it, and then you can calculate the volume of air flowing through it every minute. Then looking at the filters, again, have a look inside the ventilation system and write down the numbers and figure out what rating you have. And there are different ratings. So here, the bottom are a kind of equivalency of different rating systems to the MERS system. Air filters, again, this is kind of tricky because they often have more than one speed, and the top speed is often very noisy and maybe too noisy. And so you really need to buyer beware here, and you need to size them properly. You need to look after them. And as Kevin mentioned, the Corsi Rosenthal box that you can use with a fan with filters attached to it. And supplementary fans, they're great if they're in the window blowing out the air from the room to the outside, but if you're blowing it from one person to another, I just hope that person's not coughing or sneezing. And once you've filled all that out, you get a summary of how many equivalent air changes per hour are in this room. You can also, if you have the carbon dioxide readings, you can put them in there. And then you slap it on the door, and then people will know when they come into the room what the level of ventilation is for that room. Now, the approaches to addressing workplace health and safety have been really focusing on individual responsibilities, and this is that trend that I mentioned before, responsibilization. So there's a lot of activity enforcing masks, but not as much as enforcing ventilation, which is not an individual responsibility. And there have been lax enforcement of regulations and directives. In fact, unions have had to take the employer to the court in order to get some of the directives enforced. Now, in health and safety, some research has been done in how people conduct representation for health and safety, and the two basic approaches. One is a technical legal approach, which is obsessive rule following behavior. The other is a knowledge activist approach, which is a more problem solving and mobilization. If you want to read some more on it, there's a reference here from Alan Hall and friends. And the Labour Occupational Health Clinics for Ontario Workers Academic Research Collaboration, or LOARC, put out this booklet about representation and describing these two styles of representation. We also did a survey of over 800 workers and published that. And what we found was how representatives spend their time is quite a difference in the different styles. In the technical legal, about half their time is spent on the attending meetings, preparing for meetings, and doing inspections. Whereas for the knowledge activists, it's a much lower percentage. Whereas the knowledge activists spend a good chunk of their time training themselves, training others, doing searches for information, and organizing worker support. Whereas technical legal spent less than half that time doing such characteristics, and we found that the knowledge activists were more successful in getting changes in the workplace. And the type of things that they looked at is doing research. It's more than just meetings. You need to meet people. You need to mobilize your influence. You need to listen to workers, address authority effectively, build trust, be assertive, but also provide solutions, not just problems. Use inspections and minutes creatively, and use the law strategically. Now, here's an example. We had a lot of noise and diesel fumes in Ottawa a few weeks ago. And so a CBC reporter actually got a meter out to measure the particulate 2.5 micron diameter. And what they found was it was 14 times higher than the average. And if you compare it to the criteria for health, based on this level of diesel exhaust in Ottawa at that time, you probably needed to wear an N95 mask, not because of COVID, but because of diesel exhaust. And that's not the only source of particulate in the air. There's the forest fires in BC. They put out this special bulletin explaining to people how to use N95s to protect themselves from wildfire smoke. So learning to use masks is really a life skill. It's good for preventing respiratory diseases. It's also good for smoke from forest fires. It's also good for bad air days when the particulate is high. Any workplace that has a dust problem, it's useful. And when you're doing dusty work around the house, it's useful. So everyone essentially should know how to use an N95 to protect their lungs from particulate. So, to-do list, become a knowledge activist, assess your community risk. I should add here some of the ideas that were given in the first presentation. Evaluate your ventilation system. We have that tool. It's meant for classrooms, but it can also be used in offices and meeting rooms. And learning masking is a life skill. So thank you very much, and sorry that I went a little long.
Well, I think 301's not too bad, but thank you very much, John. There was a lot of valuable information and a lot of thought-provoking information too about what works to affect change in workplaces. We have a very quiet chat today, aside from me posting in a bunch of links to the website. And I see, Tara, that you put in information for your Zoom meetings. And Dorothy commented on, it was great that you quoted Bob Sachs. Sass, sorry. Gee, going too fast. And a few people talking about disguising their N95s with surgical masks, which is, one shouldn't think one is subversive by protecting oneself. It is a very strange societal norm that's going on right now. And I see that Tara, you shared with Marianne the CDC study about masks, but I don't know if you wanted to add to that, or if anybody who has a question that's can also, yes, turn on their video and put up their hands. So Erin, I see you've done that. We can do that now if you want.
Yeah, thanks. I guess I was just curious if you're aware of any washable and reusable equivalent KN95 masks or N95 masks. I'm not a fan of the disposable aspect, but I wanted to let you know that I think I found some by MedCareX, and in the specs it says it's an equivalent KN95, but I mean it's this cloth mask here, but it says it's got 3 layers, antimicrobial, good 95% filtration. So I just don't know if I can, blindly trust the specifications of the product, or if you have any other suggestions.
Well, first of all, the N95s are made by a special material which has electrical properties, and when you get too much water on them, they lose those properties, so they lose their effectiveness, and also those properties allow them to have less resistance. So you will always get better, easier breathing through these special ones. However, if you go to elastomerics instead on the other side, where you have, a rubber or silicone or something mask where you can put in the filters. Those filters can be exchanged and put into paper bags for a certain number of days and then reused. So that can also work. I'm not familiar with the one that you're describing, but my spidey sense says I'd be very careful, and they might have a lot of breathing resistance. That's what I'd be worried about.
Did I say something?
Yeah, go ahead, Dorothy.
Yeah, so anytime you see antimicrobial, that means that there's some other chemical that's been added. It is, and I would be wary of breathing anything that has an antimicrobial, or breathing through anything that has an antimicrobial in it. Their antimicrobial resistance is going up as a result of this kind of stuff being used so often. It's, you know, it's in socks, it's in a bunch of other things these days, you know, it's in wallpaper. So-called antimicrobials. Anytime you see it, know that we're talking toxic chemicals that probably are unnecessary. And especially if you're going to breathe it, you shouldn't be.
Thanks. Thanks for the question, Erin. I was just looking, I thought I had seen, well, there was the one about other tools or risk assessments, I think, Marianne, that you had asked. I don't know, Tara, if you're aware of any in the context of some of what you're looking into from the knowledge translation, mobilization, or the risk assessment tool that you're working on trying to pull together. Have you seen any others that, I think you mentioned masking. So Marianne's question was, have you seen anything around ventilation? You're muted.
Right. I haven't, but I think that a number of people, some of the tools that have been presented here are very effective. What I try to do, my expertise is not in the area of the occupational protections. What I'm trying to do, or we're trying to do, is help people access information that can tell them what the risk is like around them in sort of the community in general. But I think a lot of the a lot of the ventilation information that was provided here is useful. And then we are trying to roughly estimate, we're trying to do some of the numbers we're doing and say to people, this is what your risk looks like if you wear this type of mask, if you wear it all the time. We're sort of trying to spell some of that out so that people can see what a difference it can make. But that's the extent of our work in that area. And there are people here who know a lot more and probably have access to a lot more resources.
Actually, I think the person who asked the question has quite a lot of experience with different risk systems.
Yeah.
And a lot of them make a lot of assumptions, and you're only as good as your assumptions are. And so I think Marianne could probably give a talk about all the different
Thanks,
risks.
John. I really appreciate that. If you want me to, I'm actually out walking right now, so if there's background noise, just tell me and I'll shut up. Yeah, thank you so much, Tara. I just want to say how great I thought your presentation was. We really need this information so much. John is right. I've looked at a lot of tools, and that's why I'm very interested in your perspective, because you have such a good one. Some of them I think look very good to me, but I'm thinking of the ones from the University of Colorado. There's one from MIT. There's some from Australia. There's so many that, I would love to have the thoughts of people who've evaluated them. But I do think what you've provided with us really helps a lot, especially on those issues about community rates, which are such an important variable when we look at this. So thank you.
Oh, and this is very much not my expertise. I truly am just trying to figure out ways to provide information that's usable to people. So I actually would love to work with anyone else who's working on this so that I can learn more. I can figure out some of the I can figure out some of that in the background, but I am very not knowledgeable about how to make it useful. So if anyone is interested in that, or in helping or getting me involved in some of it, or getting us involved, I'd be really interested.
Great, thank you. Yeah, I'd love to talk to you sometime.
Yeah, okay.
Okay, great, thanks.
I actually had a question, and then there's a few more in the chat. I was interested in your, I think your request to sort of or the feedback in terms of how to, you know, this sort of relative risk concept, and I'm not sure about that measuring against flu. Every time flu comes up, I think like that's how they kind of whitewashed everything in the UK when they lifted all the you know, and that was misrepresentation or misinterpretation in the media or whatever. Oh, it's no worse than the flu or whatever, right? And then they just take off with that and run with it and ignore the fact of how many more thousands and even millions of people are exposed. But I guess I was wondering, with the comparisons that you're using, are you using flu rates like averaged from the past 5 years versus, because I think flu is way down, right, during the pandemic because of our protective behaviors and protective the mandates and the rules. The flu's down too. So is it a fair comparison, I guess, and is it meaningful? I don't know. It's an interesting one to me.
I don't know. I mean, the rates I'm using are just the average up to the 5 years up to 2019. Yeah. So, and they're pretty comparable to like the CDC 10-year. The US has a bit more flu mortality than we do than Canada does, but yeah, so I don't know. I don't know what people will relate to. And I think different people will relate to different things. And, you know, I suspect also that saying, listen, there are going to be more people that die of COVID than diabetes is something that I think, wow, that's a lot of people. But I don't know for a lot of people whether that means anything either, right? Whether you get to a certain age and you have family members, or you sort of start to recognize the burden of those diseases in a personal way, you know. But I'm not sure actually whether any of those are good comparisons or what people would relate to. I'm not sure. Yeah.
I've seen a few lately. Diego Bassani had some on Twitter this week, based on the wastewater and Bill Como's translation of that and he was comparing it to earlier waves, which I think, so you're looking at wastewater, you can see, okay, this is at the level that it was December 1st, and look what was happening, you know, where our curves were going then, or this is what, you know, this is what it looked like in February, and where was our curve then. But even then, because people don't know the level of death and the level of disease, are they able to really, and you know, and is it for every individual to be trying to figure this out? Some would argue no.
I don't. Yeah, I don't. Yes, I'm not sure. I mean, I think having multiple ways of presenting it over time does, or at least it helps me, I think. But then at the same time, there's the risk of overcomplicating it, right? And do you just want to have a simple kind of, you know, red, green, yellow, or some colorblind, whatever version of that, where people can say, okay, it's like, you know, is that more effective for the majority of people who don't want to wade through all the numbers? I don't know.
Yeah. There's some questions here. Nick made a comment, Aaron, about looking at the website that you'd put in, that there was no mention of Health Canada, CSA, or NIOSH. So those would all be red flags to anybody that's involved in technical purchasing, that if there's no recognition or they don't meet certain standards, then they would be suspect. And there's this question around risk levels wearing N95 or KN95. I guess there is I don't know if you want to comment on that, John, or.
Sure. Yeah. Well, KN95s are roughly equivalent for filtering, but for fit, there are Chinese KN95s come from China, and there are lots of publications coming from China that say how bad the ergonomic fit of a KN95 is. And you can have a perfect filtering mask, but if it doesn't fit tight, it's not going to do you much good. And that's the problem with the surgical masks, because they weren't intended to fit tight. And so, you know, they're about as good as putting your hand over your mouth. Whereas the risk levels with N95, again, it goes on, as Simon Smith from who used to work, does a lot of work with the CSA on this, says it's the filtering, which is a property of the mask itself, The fit, which is hopefully being fit tested so that you can find a respirator that fits your face effectively. And it's also the function, because once you have a good fitting respirator, if you're not wearing it when you should be, it's not going to do you much good either, even if you can get a good fit. So it's all those three factors together that will determine your protection. And workplaces that require people to wear N95s because of dust or other exposures, you have to have a respiratory protection program. And that protection program requires fit testing, making sure that people have the right respirator and know how to wear it and know when to wear it. So it's a lot more than the KN95s are probably cheaper, but you get what you pay for.
People like the handiness of taking it on and off, whereas, yes, we would rather they didn't take it off and on, I guess, really, right? Keep it on.
Yeah, and anything that loops around your ears is not going to be as an effective fit as something that loops around your head.
Yeah. Yeah. Okay, there's some other discussion around the comparisons. I don't know if you can see the chat, Tara, about comparisons. I think using long COVID, I don't know if Dorothy, your meaning as a stat in risk communication, it's a bit challenging because it's kind of ill-defined, but and then Nick also talking about your comparator diseases that you don't get more than once, like like a cancer. That's not true, actually. People do get different cancers, but anyways, does that affect it, the fact that it's a disease that you can get multiple times versus you're comparing the death rates on things that are more black or white, I guess. So Dorothy, did you?
Yeah.
I didn't know if you wanted to add anything, Dorothy, about your comment, or just let Tara answer.
So, Tara, I'm a longtime health and safety person, and one of the great frustrations for me is when people just look at deaths and they don't look at how
yes. Oh, absolutely. Yeah.
And it seems to me that one of the things in this pandemic is people are not, the public health people and others are going by not just cases, but they're going by how many people end up in ICU or how many people die. And that is not any kind of prevention. So, so what I was thinking about is just sort of, aside from the flu, which I think, given the arguments that people are making, well, it's not any worse than the flu. I think it's good to show that, but it might, in terms of deaths, but it might also be good to, if there's sort of something that you could find to compare it to, the long COVID stuff, or the people's lives being made miserable from getting COVID, to, something else that, well, say heart disease in general, because not everybody dies of heart disease, but we might have numbers around who's got it, the numbers that have it, or the numbers with diabetes. And since long COVID is, and COVID is associated with diabetes. So thinking of some of the common diseases that aren't necessarily killers, and looking at the parallels within COVID to not to take away from the deaths, but to supplement those numbers. So
I think that's
about what's the real life effect. Well, I'm not going to die. I might get sick, but I'm not going to die. Well, how sick are you going to get, and for how long, and what are the, so
what's the risk? Yeah.
Those kinds. That's what I was thinking.
I think, I think as long as the appropriate caveats are provided, I really do think that if we, say 20% of unvaccinated people may get long COVID, 10% of vaccinated, we say, listen, we are not absolutely sure, but this is, a ballpark estimate. And then you could actually calculate prevalence, right? You could say, what's the prevalence of, or what we would expect might be we'd call it prevalence, but how many people at any given time would be living with long COVID or living with, exactly cardiovascular disease or other conditions, and try to estimate. That's a great idea. That's a really perfect way to talk about that.
And here's the other thing, that I don't know how people do this. I just know that it's done. So I leave the epidemiology up to the epidemiologists. But the years of life lost,
Yeah, I was thinking that too.
Yes.
That's actually very significant.
And it's been used with occupational disease stuff. And so it's, it's like when I say to people who work more than, regularly more than 10 hours a day, it shortens your life.
That's me.
Yeah.
Sorry.
I mean,
Probably everybody.
but
Yeah.
or for just to be blunt about it, as I said to some guys who are using a product that some glycol ethers. I mean, just being blunt about things sometimes helps. I just remember saying to these guys who are using some floor stripping stuff, it shrinks testicles. Want to use it?
Yeah.
I mean, so things that will catch people's attention, that means something to them, that they can relate to, I think is really key when you're throwing out these.
So
talk about it. Say,
yeah.
Some of my favorite people are epidemiologists, and I use their work, but I'm not the one to play with the stats all that well.
Well, I mean, it's actually hard, like making this relatable. It's actually very hard, right? This is certainly not something that I'm kind of learning as I go along and trying things and seeing what sticks. But the years of life lost is a great, and it's not that hard to do those estimates. It's being done with COVID. It's not, it would take a bit longer to do, but that's definitely something. And then even just, like maybe thinking about prevalence, right? Of long COVID, maybe compared to arthritis, for example, which many people would, or thinking of examples that people relate to. Yeah. It's not hard to do once you estimate that basic number, right? After that, you just have to go and find estimates of what the prevalence are, the impact of other kinds of diseases to benchmark it against. But the actual estimate's not hard to do.
Yeah. Anyway, I'm so happy to. Val knows how to find me. So does John. I'm happy to.
Oh, thank you. Thank you so much. Yeah.
Pravesh, did you want to add something?
Yeah, I'm just thinking of John's work on the Stress Assess app. And I think that's a great tool. And John had some quality of life indicators there is what we are talking about. So, if John can adapt that in some way, with more quality of life and stuff, it'll be great.
He will tell you that's not what that tool's there to measure, but go ahead, John.
Oh, I'll leave it at that.
The idea is there.
Yeah, the idea is good. Maybe now that I got the mic, one of the things that's really COVID has brought to the fore, which Raymond Tellier, a virologist from McGill, brought to our attention in our group, was that public health is about prevention, and yet there has been a shift away from prevention to mitigation. And he suggested, think of this scenario: if we had 5 times the capacity for healthcare, and therefore we wouldn't have filled up the ICUs until much later, that would mean that we would have allowed 5 times more people to die before we started to do anything. And so, and I think that applies to the flu too. Like, is it acceptable that 3,300 people a year die from the flu if there are such simple things that we can do to prevent that? Wearing a mask. Now it's politicized, but it's not a great burden. It should be a life skill. And you don't have to wear it all the time. You just have to wear it when there's an outbreak and when the community level is high. And so the whole idea about prevention instead of mitigation has really come to the fore. I don't know if Pravesh or anyone wants to talk about that, but it seems to be something that people don't want to talk about.
I sometimes wonder if that's partly why Ontario has been more likely to put or keep things. Because Ontario has a low ICU capacity compared to the per capita compared to the rest of the country, and I sometimes wonder if that's why Ontario has been more has kept some
Yeah,
of these
kept them
measures in
longer.
place for longer because we have less ICU capacity than anywhere else, than any other province.
So it saved
Yeah,
us essentially, our poor healthcare.
Yeah.
And I think
Saved
they
some
were quite
people.
open about that because that's what they said publicly. We
Yeah.
don't have the capacity. I mean, a surprising observation was, they lifted the mandate at the beginning of this week, and on, I think, Wednesday, I was at an office building and every sign was gone to the washrooms, and the mask and everything had just disappeared. So,
Oh my God.
I guess there's pent-up demand, it seems. But anyways, Nick has a question. I think, Nick, can you unmute? I saw your hand go by.
Oh, sorry. I did that by accident. Sorry.
Oh, okay. Well, you've put some stuff in the chat. Is there anything you
Yeah.
wanted to add to the conversation, or?
No. I guess I would just echo John's comments just now. Like when I look at COVID, the thing that I kind of compare it to, from a health and safety perspective is occupational illness. And I think if you compare it, like in the top 10 that Tara mentioned, and Tara, it's nice to see your face because I usually just see the small Twitter, one, whereas I get to see John's, whatever rooms John is in on a regular basis. But anecdotally for my work, the level of infection, like the level of occupational illness we see from COVID dwarfs everything else put together, right? Like, I've never seen anything, like it. And, that likely has something to do, because of underreporting of occupational illness in healthcare as a sector. But, we had a hearing, the other day for Malfour Hospital, which is like a fairly big hospital in Ottawa. And at that time, the entire hospital was on outbreak and 300 staff had been infected, right? And that is a sizable portion of the number of people in total, that work at that facility. So, just looking at the amount but unfortunately, Ontario has extremely poor statistics on whether or not, and that was just what I was referencing for, from John, right? Like, when he looks at the Stats Canada, analysis, right? It's, the quality of data that Ontario has is dismal. And that's been clear from the very start of the pandemic, right? When we first started meeting with government in spring of 2020, that they were, that they were just doing a really, really poor job of capturing that. So,
yeah, if I can give an example, the Quebec, in the StatCan data that comes out once a month, in the Quebec, they have a variable about occupation, whether or not people are healthcare workers. And in Quebec, the percentage missing in that variable is something like 0.7%. In Ontario, the percentage missing is like 93%. It's just abysmal.
Yeah.
Most of the other provinces are somewhere between 10 and 20% missing, but Quebec does a wonderful job, and Ontario just does an abysmal job.
Ontario has a really high excess mortality among working age adults as well, is something that Ontario and BC. So during COVID, there's a particular, those two provinces have had, and this is after adjustment for drug deaths and others, but they've had unusually high excess mortality among working age people. Anyway, it's something that yes, we still need more data on that, but there is something about it that's really, and Alberta, but Quebec, it's not that it's strangely low, it's just Ontario and BC and Alberta are so much higher, but especially Ontario and BC. Anyway, just that's really interesting to know.
John tries to do an analysis every month trying to keep track of healthcare worker infections, although it's become even more challenging than ever, I think, John?
Oh, I started off counting the just infections, but now I've moved over to hospitalizations because who knows what the Now, maybe if we got together and you could help me adjust my data.
Well, you know, I mean, that's the other thing I'd be interested in is what major causes of occupational illness are, because that's not something that I'm as familiar with. And maybe that's something that I can try to contextualize some of these numbers and say, this is what the impact for employers, right, or decision makers, and say, this is what the expected impact would be on the workforce compared to the other, you know.
Yeah. Well, for cancers, generally, the number of the proportion of cancers that are work-related are generally estimated to be between 5 and 15%, although there's been arguments for as high as 20, 25%. So especially cancers like lung cancer, bladder cancer, things like that. So it's a good proportion of the cancer burden. CAREX is an organization that does a good job of looking at that, and also the occupational research or the Occupational Cancer Research Center in Toronto.
Yeah. Okay. And it's clear if those are between 10 and maybe even a quarter of all cancers, then in that case, COVID actually will dwarf that. Like there's, you know, if we're talking about the next year. Oh, that's interesting.
Yeah. The other thing that I would look at, because I've been in the state, worked in the States, is Paul Lee's work, Leigh. He's at UC Davis. And he can work around looking at the costs of occupational disease. And for that purpose, he pulls out numbers around what he thinks are linked outcomes that are linked to jobs, and what proportion he thinks, if I remember rightly, what proportion he thinks might be linked to the numbers might be linked to jobs. There are other people doing that, but Paul Lee is sort of one of the more interesting ones, and one of the people I sort of count on for that. But part of the issue is when it comes to jobs is that you know, so often what doctor would ask, you know, when was the last time your doctor asked you what you do and actually understand? And if you said you were a blast furnace, what would he or she understand what that meant? And there's this whole sort of system that doesn't allow us to know what's really going on. And so, you know, so estimates are great, but that's the best we can do because people don't ask the right questions in the first place.
Yeah.
Sorry, I'm counting cards here. Pardon me.
That's okay. I think it is past 3:30, so we've already kept people and kept you as our speakers already an extra 25% of the, since we're using, you know, math, 25% of the session. So so I think we should probably wrap up. But I would invite each of you, I guess, if you have any final comments just related to your presentation or the context of today, and for the audience, I guess, and you know, the subtitle of the talk was around managing uncertainty, and I think we're all still finding ways and trying to shine more light on information, and in trying to get more tools, and in trying to help patients and workers. So, but anyways, I won't keep talking. Tara, did you have anything you wanted to say in final remarks?
No, not, I mean, except that you know, I would be very interested in working with people. And then I also do just want to come back to the idea of gratefulness. I know that we've been talking about a lot of terrible outcomes, and I, for one, am angry, and there's so many things that are difficult, but I am very grateful that I personally have the protection I have, and I think many people don't, and that's a big part of what I think is why I keep doing this, because many people don't have the protection and privilege that I have. I'm so lucky, right? And things you know, they will get better and everything else, but there are so many people who are just out there on their own, and it's really distressing, you know. But I'm very grateful.
Thanks. Yeah, it's a good reminder. How about you, Pravesh? Did you want to add anything?
No, nothing specific, but just to say that, you know, being grateful is all about self-care. And when you take care of yourself, you can take care of other people. So start with yourself first.
That sounds
Thank
easy.
you, sir.
You mean I'm supposed to stop work as soon as we get off this call?
Yep.
Not quite yet. It's funny how weekends loom when you think, where did that week go? John, did you have anything else to
Yeah,
add?
following up on that self-care, wear your mask. Don't take it off yet.
Yep. Yeah.
You can probably take it off this summer if things go well, but it's a bit too early. So just keep it handy.
Yeah.
And do what you can outdoors, I think, right? Already now the weather's lightening up, that you can arrange to talk to people in the parking lot or on the sidewalk instead
Yeah,
of
my window's open.
yeah, don't stand in the hallway and talk to somebody. Let's take it outside, but not in the same way, I guess, that we associate that. So
Well,
I would like
let's hope it doesn't get to that.
yeah,
I know
no,
that there's a lot of
exactly.
polarization, but
Yeah, no, that's unfortunate, and yeah, that's important. So, you know, what we've been talking about today and what our tools and, you know, is trying to have conversations in workplaces so that there can be respectful dialogue and people can understand that there is an element of risk and from a precautionary perspective and from a business continuity and sustainability perspective, it's better to be err on the side of caution where possible. So it's anyways, we have another session on April the 5th, which is actually about mental health and mental health impacts on frontline workers. And I'm really looking forward to that. And it's posted on our website. Actually, I should link that in here, although we'll send out an email so everyone will have it. And I would like to thank everybody who's still here and who joined us today and keeps coming back. Because we're trying to do our best to translate knowledge to make a difference in workplaces. So thanks to the speakers again, Tara, John, Pravesh, and to Kevin and to Kashif in his absence. And thanks to all of you. Have a good weekend and stay safe and healthy.